One of the issues that is top of mind for IO now is finding biomarkers to select patients and to stratify them so that the most likely people to benefit from that therapy are the ones who are, in fact, that are treated. Even though immuno-oncology drugs, specifically the checkpoint inhibitors, have remarkable effects on a minority of patients, not all patients respond. So our biomarkers and our companion diagnostics are good, but they need to be great. And there's a lot of work that's going on to try to develop better biomarkers, but also it's important for the community practices to understand how best to use the biomarkers that are still out there and that are currently out there, because those are also somewhat contradictory data. So we help them navigate how to use these markers to stratify patients and to select the best patients for therapy.
One of the big challenges right now in the world of IO is determining who is going to be a responder to therapy. We have a select number of biomarkers, but we need better biomarkers and better ways to select for patients who are going to have the greatest response so that we can use these drugs in a more targeted fashion. I think big data has a potential to help us with determining who should be tested.
We're in an interesting period in which clinical trials are really changing. We used to do clinical trials because the regulators required that for every indication separately. And we repeated them just to make sure that it was okay in a certain indication. Now that treatments are not anymore for a specific disease, but for certain mechanisms of disease, for certain genetic profiles of patients, we should really be looking at doing trials that cut across the different patient populations, irregardless of the type of cancer that they have or the location of their cancer. If indeed a mechanism of action cuts across many disease manifestations, let's design trials that are focused on the mechanism of the disease, because that is really what the treatment focuses on.